Hi, everybody. Good morning, good afternoon, good evening, depending on where you're calling in from. Welcome to this month's session of the Global Neurology Forum. I'm Camelia Rodriguez-Sackburn, and I'm with the Global Brain Health Institute. I'd like to welcome participants from around the world, joining by Zoom, and those here in the room at UCSF. A special welcome to any fellows and senior fellows from the Equity and Brain Health Program. The Global Neurology Forum series provides an opportunity for learning and dialogue about the diagnosis and management of neurological conditions. The forum aims to help participants from around the globe, including in remote areas, respond to challenges in brain health. The series is co-presented by the Global Brain Health Institute and the Global Teleneurology Service programs in the UCSF Department of Neurology. GBHI is a partnership between UCSF, Trinity College Dublin, and Atlantic Philanthropies. We want to give a special thanks today as well to the Care Ecosystem Program. Today's session will focus on a case study to consider our theme, Who's Protecting the Elderly? Before we begin, just a few housekeeping items. Today's session will be 90 minutes. It will be recorded and shared out afterwards for educational purposes. If you are here in the room, please add your name to the sign-in sheet. It's floating around. Everyone on Zoom will be muted until the Q&A portion of the program, and we ask that you also please mute yourselves to avoid any background noise. Please feel free to share any questions in the chat box, and Michael Schaffer, who's here, will help flag those questions for our speakers. Today, we're going to hear from Boon Lee T, who is a neurologist and an Atlantic Fellow, as well as Jelaine Arias, who is an attorney and also an Atlantic Fellow for Equity in Brain Health. Thank you so much. Enjoy the program. And I'd like to welcome Boon Lee up to begin.
Well, thank you, Camelia, for the kind introductions. Good morning, good evening, good afternoon, everyone. The title of our discussion today is structured as Who's Protecting the Elderly? Before we proceed further, I would like to say that we have no financial disclosure, but the information of the case presented here today is partially modified so that we can protect the individual's privacy. So we'll start by introducing the clinical case, first with the clinical aspect of the case, and then shifting gears towards the social aspects of things. And then we'll build on some of the information that we have gathered around elderly placement as well as elderly mistreatment issues. And then Jolene will kindly grace us on the legal aspects of elder protections. And then at the last session, we would like to open the discussion for everyone to kind of give us, share their own experience about this issue with us. So welcome, Jolene. No. Okay, so let's start with the clinical case first. So I would like to introduce you to Michelle, which is a very nice middle-aged lady that's born post-World War II era, right-handed, highly educated, and has a relatively simple past medical history of having dyslipidemia. So her clinical story starts at around the age of mid-30, where she actually retrospectively recalled that she has smelling problem. So she was having difficulty, insensitive to smell. And then by the age of 52, she actually has noticed that she has less facial expression. And then she was having difficulty in retrieving words in her daily conversation, which actually prompted her to get medical attentions. So when examined by a medical team, she was actually found to be bradykinetic. She also having some shuffling gaits as well. In addition to that, she was, those bradykination and shuffling gait was quite responsive to levodopa. She was also, having difficulty in remembering recent memory, and then was put on Aricept, which she was also quite responsive to. And then she has trouble, tipping when she goes for dining. And at the same time, she also noticed that she has difficulty parking, likely because of navigating within the parking space. So she was actually treated with Aricept and levodopa at that time. And then fast forward to age 54, she starts having some visual hallucinations. Some of the things that she described was she's seeing faces at some of the chairs in the house, or that she would see shadow flying by. But she seems to have an insight that those are hallucinations and she doesn't mix them with reality. So afterwards, a few years later, at around 57, the husband actually noted that she has some REM sleep behavior disorder. There was some issues. So there was some documentations that she accidentally hit him during sleep. I'm guessing it's unintentionally. There was also some issue on complaints of diplopia, which the ophthalmologist assessed her and then documented convergence insufficiencies, and also noticed that there was some depth perceptions problem. She at the same time was also developing some lightheadedness, which was later found to be attributed to orthostatic hypotension. She also had some urinary incontinence issues that she requires pads and help on, going to the toilet regularly. And she was actually having some neuroleptic sensitivity. So certain drugs like zolpidem, Rivotril, she doesn't have the best response to them. Like, for instance, on zolpidem, she has some disorientation as well as dystonia. And then by the age of 59, she actually developed some truncal rigidity. So she was having difficulty getting out of bed. She needs help for that. She was also developing apraxia, like she doesn't know how to put on her backpack. So she needed help on that as well. And then there was an issue, there was an event where she actually tried to cook food directly on the stove without the pan. So there was, it wasn't new stove to be fair, but still it was somewhat of a concern, I guess. So she was actually first seen in the MAC at age 59. So in short, I won't go into every details, but in short, she was having some hesitation because of word retrieval problems. Cranial nerve was at large normal, but there was some saccadic intrusion of pursuit, slowness of saccade initiations. And then there was some Parkinsonism features as well. So she was slow on rapid alternating movements, some cogwheel rigidity, right worse than left. And then there was also some postural tremor, high frequency, low amplitude. So I'm not going to the details of all neuropsychs, but in general, I think we can, so I highlighted anything that is abnormal in the abnormal range based on her education level and age in rate. So you can kind of see that she actually was quite slow when it comes to executive functions, and some of the, partly maybe due to her motor limitations, because she does have some bradykinesia, but those that are not requiring motor function as well, like semantic fluency, proverb, digits span backwards, she also didn't actually perform quite well. So there were some concerns of executive dysfunction, so processing speed. She was also borderline low on PVVT and BNT, which actually correspond to her word finding difficulties. And then she was also slightly high on her GDS score. So going through her MRI, I'm actually scrolling through so you can kind of have a sense of what her MRI looks like at the age of 57. So this was done before she actually visited the MAC. So there was actually some dorsal parietal slight atrophy, which can be compatible with her age. There was no, at large, we don't think there was definite abnormal atrophy when at the age of 57. So looking into her family history, so we kind of gender neutral all family members, but you can see that the one with the arrow here is actually Michelle, and the one highlighted in blue boxes are actually, I think, family history that we are more concerned of. So one of the grandparents actually developed organic brain syndrome with paranoid dementia, lived quite a long life till the age of 86 where he died of stroke. One of the parents was suffering from Parkinsonism and dementia with visual hallucinations at the age of 50s. One of the siblings was also having RPD at the age of 30s and then eventually evolved to Parkinsonism with cognitive problems problem at the age of 50s. So naturally, this was somewhat of a concern because each generation we do see someone that has somewhat of a similar features. So there was a concern of autosomal dominant inheritance pattern. So naturally, we proceed with genetic testing. So what I can actually found was she was tested negative for LRRK2. She was also tested negative for SNCA. FBX07, she has a rare missense mutations, but was not deemed to be functionally relevant. However, on her GBA gene, she was heterozygous for rare missense mutation G193E. We can discuss more on that, but briefly, this mutation actually causes the enzyme to have like a functional activity of 7% of a normal enzyme. So it's actually deemed to be strongly functional effect. Whether it actually constitute to autosomal dominant Mendelian inheritance kind, I don't think we would go to that degree, but it does likely increase the risk of developing diseases. So, so one thing I thought would be helpful to highlight also, at the age of 60, you can see that Michelle is a very active person. She actually took the initiative to go to an attorney and then establish her power of attorney. So she at that time she decided herself that her financial POA was her husband. Medical POA was her sister, and the event where there is difficulty in paying her medical expenses, her sister would step in with a backup conservatorship to take over the financial POA. So coming back to the clinical story, she, at the age of 61, she was having difficulty reading. And then at times, when she was really tired, she noticed that people's head would disappear. It is actually kind of scary to me. So I can imagine it would be very challenging for her. And at that time, she was also found to be quite socially isolated because she can't drive very early on. She has to be dependent on other people driving her around. And her husband wasn't totally on board on that. There was also an increase of medication frequency because she was having a lot of orthostatic hypotensions, and generally Parkinsonism's medications would have that side effects. So one way of overcoming it is to divide it into more frequent dosage, so more frequent dosage, but the same dosage amount. So, so keeping up with that was also quite challenging. And then she starts having some fall episodes. So age 62, it becomes very hard for her to kind of differentiate the visual hallucination from reality. She was also having a tendency of taking more sweet food. So even though she was not having the best healthy diet, though she's having something, but it's not healthy. And then, so I think 63 years old, there was this event where APS got involved, which will going to be the focus of her social part of the history that we probably would discuss later. But in short, there was this event where she woke up having extreme dizziness where she can't walk or stand up. So she requested her husband to bring her to the ER, but I think the husband wasn't keen on that, so she has to call her daughter to step in and bring her to the ER. So I think in the end, I think the ER personnel was leaning towards orthostatic hypotensions, but because of how the event evolved, there was a bit of concern of caregiving, concerns, negligence or safety concerns, in which they kind of approached the PCP and neurologist, and then they sat down and decided to, file in an APS report, an Adult Protection Service report, to notify of such concern. And we'll talk more about that later on. So that happens at age 63. And then by age 64, she was having arrhythmia, and then her gag reflex has reduced somewhat. So that's where we start concerned about swallowing difficulties. So I think the PCP kindly brought up the issue of physician order for life-sustaining treatment. So I guess she then decided with her family that they are more leaning towards DNR with no feeding tube. So by the age of 66, she was found to having, missed her medications and was not well fed. She was dehydrated. She fall and then displaced her metacarpal bone. Her hallucination had evolved from visual into tactile and smell sense. So she starts smelling imaginary fire. She feels that there's bug in her ear. So she was later on placed into a senior facility to have a better, supervision and care. So by the age of 67, she was quite hypersomnolent at most time and wasn't totally responsive to medications, or if she was responsive, it comes with a range of side effects. She was also having frequent UTI. And at that time, actually, she has already gone through her retirement savings, and she needed to sell some of her rental properties to afford her medical expenses. So by the age of 68, one time she was admitted for urosepsis, and throughout the treatment course, she was having difficulty swallowing, and there was either an option of feeding tube versus hospice care. And in order to respect the patient's wish, I guess the family then discussed with her and decided on moving towards a hospice care. And then so she completed her life journey in a, I would say, somewhat of a peaceful way. So in short, we are clinical summaries that we are having a middle-aged right-handed woman presented with insidious onset progressive atypical Parkinsonism with cognitive impairment more leaning towards the dysexecutive side. Also have some very frequent visual hallucination and autonomic dysfunctions. So I would just like to touch upon the neuropathology, and then we'll proceed towards the social stories. So I'm not going to get vote. We'll just reveal the answer. We'll have voting later. So this is an alpha-synuclein immunohistochemistry staining of the amygdala, and you can see that the red is highlighting the Lewy bodies, and the yellow arrow is highlighting the Lewy neurites. So we can see a lot of deposition over the amygdala. Same is actually also found over the hippocampus area, also over the middle frontal gyrus. So you can see a lot of Lewy body, a lot of Lewy neurites. And then we also found them in our frontal eye field, which suggests a Parkinsonism Brach stage of 6. In addition to that, when we look at H&E stain, we actually found that there was very, very pretty Lewy body over the substantia nigra, the one highlighted here in red. So this is what a typical Lewy body looks like, homogeneous, round, and then with a peripheral halo. This is within a neuromelanin neuron. At the substantia nigra. I just can't help, impressed about how pretty that is. So pathological wise, primary diagnosis was Lewy body disease with diffuse neocortical type, Brach stage of 6. There was some incidental diagnosis of vascular brain injury, lacunes over the left basal ganglia. But you can see that generally speaking, she was quite low on Alzheimer pathology, A1, B1, C1, meaning that she doesn't really have much of a neuritic plaque, mainly diffuse plaque. Her Brach stage was 1, so suggesting that AD was not something that contributed to her clinical symptoms. Okay, so on the, caregivers side dynamics, clinical social story. So I think, actually reading through her notes, I was so impressed and inspired by this woman. She was just very considerate. She tried to think everything ahead, plan everything ahead, and, kind of relieve the family of burden of, like things of having to make the hard decision for her. But even though so, you can see that, caregiving her was somewhat still quite challenging at some point. She would do all the legal planning, all the, end of life issue early on. But her disease was particularly challenging, I would say, more than maybe most of our dementias. So she has autonomic dysfunction, so she needed like very frequent medications. She has difficulty toileting, which sometimes would be quite challenging as well. She has difficulty in mobility, so she needed someone to help her get out of the bed. She needed someone to, prevent her from fall. She was also socially restricted because she very soon after she started to exhibit symptoms, she has difficulty in driving. There was also some apraxic issues, so even like daily, functions like dressing would be kind of a challenge for her. There was also some judgment issues exhibited by, the way that she uses her stove. And also, I think the hallucination was, I would say, a very huge emotional burden for anyone. So trying to, decide which is, reality and which is hallucination was, I think, somewhat of a challenge. The other challenge she kind of faced was, I'd like to introduce you to Michele's husband, Tom, on the left. So it was hard for both of them to actually be on the same page, I would say. So In general, I guess from the family as well as some of the social worker notes, there was a strong denial from the Tom side that especially on the fact that Michelle is sick, and at one point he actually refused to have the bedside bedside commode at the bedside. So he doesn't want to see anything that reminds him of her having an illness. So he also expressed that he's one that values his privacy, and so he's not totally happy of having caregiver around the house. He felt that that was really uncomfortable for him. One thing was also very challenging was he wasn't very keen on bringing her out. He felt that he would try to avoid any possible occurrence where he would have to bring her to a restroom, public restroom, a ladies' room, and then he doesn't feel like he wants to go into a ladies' room to help her with what she needed to be, what assistance she needed. And then there's also like she wasn't when she was approached by the APS team. He doesn't feel that it was necessary that Michelle needed 24-hour supervision, despite I think the medical team kind of suggested that. And then on the long run, he was also quite concerned whether that would be a financial problem in the future. And so when the APS actually got involved, he becomes quite defensive. He felt that maybe he was being wrong, he wasn't being understood. So I get that from the social worker as well as from the family. I think the APS personnel actually visited the resident, but however, there was a conclusion that there was no physical abuse and no feeding and hygienic neglect. So they leave it to that, and then there was no further follow-up as far as we know. And so actually her sister was really kind enough to step up and then step in and help with setting up a better caregiving support for her. So she listed out all the caregiving requirements, talked with the husband, Michelle, and Tom, and then decided on hiring caregiver, and then was like pretty much trying to be on board on the medical visits as well as the medical decisions. So just a few phrases that I actually noted from some of the notes that I thought would be helpful for us to kind of have a picture of what's going on. So there was one that Michelle was asked what he think Tom was went about his disease, and she kind of like phrases him as an ostrich with his head in the sand when it comes to her disease. So, and then when there was the APS event, she was asked by her sister, as in, after the discussion, how was things? And so she actually replied, he's filming. And then after some silence, she said that he's won. So there was this bit of, when I read that, I feel like, oh, there's a bit of sense of defeated kind of feel. But however, when I actually later some of the later notes, actually I saw there was this documentation of the social worker talking to the husband, and he actually also shared some of his struggles. So he was really angry about the disease and how he felt that it robbed him of any possible relationship with Michelle. He also expressed that he does not want to be a caregiver. That was not something that he signed up for. So he wasn't able to caregiver for her, but he sold their rental properties to cover her medical expenses at some point. And I think he actually did express gratitude and thankful of all the friends and family that helped support Michelle throughout the course, but was also somewhat embarrassed that he wasn't able to be more involved, I guess. So that's the clinical side of the story. Social side of the story, I guess. So we like to. So I think this is a very unique platform that we can engage people from all around the world to share some of their experiences and learn from each other. But before I guess we go into the discussion session, I thought I can share some of the knowledge, some of the information that we read about elderly mistreatment, and then Jelaine would grace us on some of the legal aspects of things. So I guess when I actually gone through the notes, I was quite touched at a certain degree. So it kind of struck me, when discussing with the family that, abuse and negligence comes on different spectrums. So there's one end where is physical abuse, and there's the other end where there's verbal abuse, and then there's one end that's abandonment, then the other end is just negligence. So we felt very compelled in acting when it's on the other end, like on the physical abuse and abandonment side. But we are less, motivated to act when it is on the verbal abusive side of one being neglectful, but still providing the basic needs. And then I also find that, it strike me like how we actually strike a well balance in between one being respectful of the individual's autonomy, but at the same time protecting them from, harm as well. So just to kind of like show the magnitude, I think, so we all know that we have a rapidly increasing dementia population, but we also have a rapidly increasing elder population, regardless of where you're from. You're not exempted, but this is actually more true for Latin American, Caribbean, as well as Asia. One thing I found was interesting was when I was looking at it. So one is more susceptible to abuse when one is more dependent to other people. So when I was actually checking on the dependency ratio, so dependency ratio is the population number of people that's dependent divided by the population number of people that's the working force. So we are actually ranging, no matter where you are, you're ranging about 7 to 9. So meaning that any given working individual, you are actually supporting 7 to 9 dependent people. And when I am actually referring to dependent people, that includes young children, but also elder adults, as well as disabled populations. And this is growing quite fast. So like by 2050, we are looking at 10 to 14. And so among them, actually, a large portion of them are actually dementia population, showed here in the left. So we are 30 to 60% of them are actually dementia populations. Depending on your country, it varies a bit, but dementia is definitely a very major contributor when it comes to dependency. So one thing I was also curious is that, so, okay, we know that dependence. So what are the, kind of institution, or like, where do they live? So then we can know like what kind of issue we are facing here. So majority of them, regardless of your income country, you still actually reside at home or in the community. I agree that that's less so for the high income country, but still the majority is at home or in the community. So it becomes that household is actually very important. So to understand, to get a glimpse of household, I thought it would be helpful to look at the household size of different countries. So the darker the shades of green, that means you are having a larger household. The lighter it is, then it means that you are a smaller household. So generally speaking, North America, Europe, Russia, as well as Australia has really, really small household. Not really, really small, but quite small. Then we have those that are like in some part of Africa, Southeast Asia, Pakistan, Egypt, having somewhat of a larger household. And I think Latin America is somewhat in the middle. So, what does the household structure look like? So if you divide the household structure of the elder populations by, whether they live alone, which is in blue, and then the red is in whether they live with spouses or whether they live with children, and then others is in purple, you can see that in North America and Europe, actually most of them either live alone or live with their spouses. The percentage of them living with their children is not high, but this is not, this is like the opposite when it comes to Latin America, Asia, or Africa, where the majority of them actually live with their children, which can kind of also explain why they have a larger household size. So, so if they live in this kind of family structure, how many of their primary caregiver are their spouse? So if you look at roughly from ADI studies, ADI report, you can see that spousal being the caregiver, the primary caregiver range around 40 to 50% in most countries, with the exception of South Asia and Central America and Caribbean countries. So which suggests that, in Asia and Latin America, so they live with their children and then they have lower spousal caregiver. So likely maybe their children have stepped in as a primary caregiver. Whereas in Africa and Latin America, South Latin America or tropical country of Latin America, even though they live with their children, it seems that their spouses still remain their primary caregiver. Maybe people can share their thoughts of it. Europe and North America is that they tend to live alone or with their spouse, so naturally I think spouse will be their informal caregiver. So more towards our topic today, I kind of was wondering, how people define elderly abuse. So I went through and found the WHO definition. So they kind of define it as a single or repeated act or lack of appropriate action occurring within any relationship where there's an expectation of trust, which cause harm or distress to an older person. So being negligence is also one, and then the relationship is likely someone that you expect to have somewhat degree of a trust there. So they actually kind of predict that 16% of our elder population has suffered from abuse. So that's actually quite high. That means that every 6 of our elder populations, one would have an abuse experience before. So there's different kind of abuse, but more relevant to our case today, I guess the emotional abuse, this is actually highlight the medium prevalence of emotional abuse. So you can see this, it's particularly high in UK. Maybe Claire would like to talk about that later. US is around 7%. Congrats to our colleagues in Ireland, they are only at 1%. China is 27%. But when you look at negligence, it's somewhat of a different story. So you can have very low negligence, whereas more negligence are actually seen in Egypt, Israel, and a certain degree in China and Spain. So I guess different family structure and cultural structure actually constitute to different kind of concerns, I guess, mistreatment concerns. So there are a few kinds of concerns that's likely few forms that's likely taking. So there's like physical abuse that we kind of would think of immediately, but there's also psychological or emotional abuse. And then there's some sexual abuse, financial exploitation, as well as negligence and abandonment. So abuse can have very bad consequences, that it can cause the victim to be, having health problem. But at the same time, I guess it also causes a lot of psychological problem that can, increase one's suicidal risk. And so every year, actually, US is actually spending 5.3 billion on medical costs from violent injuries from the elder people. So that's actually quite a lot. But, we talk about 16% of the elder population being abused, only 4% are being reported. So the report rate is very low, likely because there's fear of retaliation. So there's not a good protective system involved at the moment, I guess. There's also some worrisome that, they would get the abuser in trouble because they are likely their loved ones. Some of them are mentally incapable, so they are not able to, seek for help. And then they feel ashamed or embarrassed because of it. So they don't want people to know about her struggle. So emotional and financial, as well as neglect, are actually the few that's very more common one. Female are actually more likely to be abused. And one thing I find was interesting was abuse is also more likely to be reported in the institution. So I'm not saying that abuse more likely happen in the institution, but they are more likely to be reported. I think there's a difference there. So what are the respect of one being abused? I guess you can look at it from the victim side. So if the victim has a history of violent perpetrations, or ethnic minority or cognitive impairment, that increases their risk of being abused 3 to 6-fold. And other likely risk factors include, life dissatisfaction, substance abuse, social isolation, low social and economic status, as well as one being single or widowed. If you, from the perpetrator side, I guess that includes the perpetrator having mental or neurological disease, they are having a very high caregiver burden, or they are having substance abuse, low education, low self-esteem, and history of violence perpetration. So relationships, right, quite naturally, one that doesn't have a good family relationship or that they are living together, is easier for them to have abusive relationship. So generally, I think WHO is estimating 2 out of 3 of dementia populations are being actually abused before or are currently experiencing it. I just thought it would be helpful maybe to just share one slide of what I gathered from Taiwan. So this is actually a graph of like how Taiwan abuses case report is at the moment. So so actually it's increasing quite remarkably, mainly because that the media reported a few huge cases of elderly abuse for the past few years, and then there was also some change in policy. But still, our case reported is estimated to be 1.4%, which is so much lower than the 4% WHO is so it's reporting. So unless we are a very exceptional country, it's not likely that that is the case. So we still have a problem of highlighting those cases. There's a few reasons why culturally, I think. So there's a lot of Chinese idiom around this. So one of it is called 家丑不外扬. I'm giving you Chinese lesson. No, I'm kidding. So it actually means that you don't air your household dirty laundry in the public. So we just don't talk about anything we find that's not pleasant in the household. And the other thing is that 法不入家门, which means that law doesn't enter your house. So anything that's household related should not be solved by legal ways, which not really true. There's also divorce, but anyway. So then also I think Chinese community are put a lot of emphasis on education. So if you are not able to educate your next generation to respect their elders, you are actually considered as a very failed parents. So you are actually partly responsible of it. So I think that's also why they hesitant on bringing things up. There's also some discussion when I was reading some of the literatures about transgenerational violence or repayment theory. So the thing is, Chinese community believe in physical punishment during your childhood years, somewhat degree, I think. So so if you're exposed to physical punishment in the very early on years of your life, there's a tendency of you being abusive in the future. And then so that's that problem as well. And then there's another problem that's probably more related to law that maybe Jolene will probably give us some perspective on this. So in Taiwan, it is against the law for you to abandon your parents. It is an obligation of children to take care of their parents. So in the event if you don't take care of them, you can be charged in the criminal court as well as the civil court. So you can look into a jail time of 6 months to 5 years if just purely because of abandonment. And if your abandonment causes life-threatening conditions, you can be imprisoned for life. Not to add that you have to pay monthly alimony for if in the civil court. So I guess there was some change regarding it. I think they set up this 24 hours hotline and a more unified window. So one thing that people was criticizing was, different kind of abuse goes to different departments, like physical abuse go to the medical side, and then there's then the police side, and then there's the, like the emotional side, emotional abuse then goes to maybe the social side. So it becomes very complicated. So one thing that they did, I think was also quite reasonable was they set up this unified window where people just need to call down 113 with the Taiwan phone though, then you'll be able to connect, and then there will be someone that help you sort things out. So, okay. So I guess maybe we have a moment here. So this is actually a voting line. So anyone that's interested can go on this link. And so I guess there's a few questions there. So like one thing is that, do you think you are comfortable with, the elderly mistreatment policy in place in your country at the moment? And then who do you think should be in charge of changing or making it? If no, then like who do you think should be in charge of making this different? And then is there a one-size-fits-all solution that we can all lean towards in tackling this problem? So let me see. So, okay. So
vote for 3 minutes
yes.
or something?
So it should be running now.
Okay. Go back to the question.
Yeah. The QR code also link to the vote. So you can also use your QR code to kind of have a look at them. Is it working? Okay, is everyone finished with the first question? Okay, awesome. So I think the second question is popping up.
Testing, testing.
Is everyone done with the voting? So I'm actually very intrigued. So let's look at, whether I need to go back to the first one. So there's some people that's still quite satisfied with their policy in their country. Is it possible for me to know who was the one that said yes? And we probably should learn from them, No one here? Someone on the Zoom, maybe? Okay.
If somebody pops in, I'll...
Yep. Okay. And so who should be responsible? I think the majority thinks that policymakers as well as healthcare providers should be responsible. Less so for the police though. Teachers and educators, elderly. So I'm actually intrigued by others. Is there anyone that wants to share what they have in mind for others?
Hi, it's Eliseos. Yeah, the concept and the reason mentioning it was that at the Prince Mahidol conference, there was a mention of transitioning from healthcare systems to systems of health. And that means that any aspect of our society could aim or could help everybody by having a healthcare component in it. So it's not a matter in my mind anymore just having a healthcare system or a policy system for healthcare. It's a matter that the entire society is geared towards healthcare provision at any level. So everybody.
That's actually a very good point, I think. So I think everyone can contribute in a different way, which is actually very important to point to think about. So with the poll, I'm actually passing the mic to Jolene, and then she's going to talk to us about the legal aspect of elderly protections, and then we'll open the floor to discussion.
Thank you so much and good morning. So I wanted to start a little bit by talking about the context of what we mean by elder abuse and mistreatment. Sorry, I'm getting, oh, okay. There we go. Okay, I'm getting instructions from Michael about how to speak into a phone or microphone. So the first thing to keep in mind is just the context, particularly in the US, and I'll say most of what I'll be speaking about today is about the US because that's both where I'm legally trained and where I've practiced as a clinical ethicist. So this is my experience. So something to keep in mind is that we all know, it's pretty standard understanding that informal caregivers, including family members, friends, and even people such as neighbors, are providing a majority of the care for patients with all sorts of neurodegenerative illnesses, but the elderly in general. And as a result, that puts an incredible pressure on our social relationships. It's also important to know that the baby boomer generation is dramatically changing the demographics, both I think in the US and then also globally. And so what that means for a demographic around caregivers is that we're actually reducing the number of available caregivers to any individual who needs support. So the estimate is that we will go from about 7 caregivers available for any individual that needs support to maybe just 3 in a very short period of time. So what does this mean for caregivers? It means that instead of having a full community of people to rely on to provide respite care, we're actually relying on a far fewer number. And that also means that when somebody says, I don't want to do this, this is not something I feel comfortable with, which should be within their rights to be able to say, it removes the number of available people who can step in to help, and again, increasing the pressure. And I think particularly concerning in the United States is how we're paying then for the formal care that would then help step in to help our informal caregivers. So in the United States, only about 10% of individuals have private long-term care insurance. What this means is that they have to rely on other forms of paying for services like either whether it be a nursing facility or in-home care. This is something that our social workers and our nurses know very familiar because they're having to come up with solutions for families that don't rely on the paid services, and this can be really complicated. Another huge issue in the United States is that people don't actually know this piece of the puzzle. They don't know how long-term care services are paid for. So when they get to the place where they actually need them, they're not equipped with the information to be able to make good decisions. So there's a large misperception in the United States that Medicare, which is the primary funder for and payer for health services for our elderly in the United States, or that health insurance would pay for long-term care services. And in fact, that's not true. So what ends up usually happening, particularly for our middle class, is that they spend all of their assets in order to do this thing what we call spend down, which essentially means getting your financial assets low enough that you qualify for Medicaid. Now, while this can be a solution to the problem of needing access to services, there are limitations about what kinds of services Medicaid can provide and how those are provided. So for example, in many states, there are a limited number of spots for at-home care, meaning that Medicaid says this is how many people we will provide at-home care for. Once we get to that, everybody goes on a wait list. And as a result, then we're back in a situation where people aren't receiving sufficient formal caregiving service, and we're again putting more pressure on our family members. Something else I want to highlight from a legal perspective, and I don't want to get too down into the weeds of law because nobody wants to wake up at 8 in the morning on a Monday and talk about law, unless you're like me, who geeks out over this stuff. But I will just say that in the United States, because of the way that our legal system is structured, we do have one overarching federal law that is meant to provide protections to elders. However, at the end of the day, this really is a state responsibility. We have delegated and given states the authority to make decisions about what constitutes abuse, when there should be interventions, and how that is managed. And this has also resulted in a large range of definitions of what constitutes elder abuse, what constitutes mistreatment. And I think that also causes a lot of confusion in the system about when we reach a threshold where APS, Adult Protective Services, or other state agencies should be stepping in. And we end up with this really uncomfortable gap. And I think it's uncomfortable both for the caregivers, I think it's uncomfortable for our clinicians and our social workers and the community in general, because we all have, I'm sure, had some incidents where we had an elder in our life, maybe that we knew indirectly, that we were concerned about. You know, maybe it's even the woman you see in the grocery store or the man walking down the street that you wonder, is this person getting the care that they need? And we come onto this gap between patients who we can say, gosh, they are receiving gold standard care. This is awesome. This is exactly the type of care we would hope that our grandmothers or our mothers or our fathers would see. All the way to the other end of the spectrum, which is like, this is absolutely clearly abuse. And that it is a spectrum. And one of the reasons why it is so challenging in that gray zone is, again, because states handle elder abuse and mistreatment differently, we have this gap. And also APS, Adult Protective Services in the United States, is incredibly strapped with resources and a very high caseload. So let me tell you how this ends up taking at play. And I think we actually saw it a little bit in the case that was discussed this morning. Generally, a healthcare provider who has a duty to report will ping APS and say, hey, Adult Protective Services, I have an issue of suspected abuse or negligence here. And the caregiver may or may not know about this consult at the time, But ultimately, adult protective services will do like a 4-step process to identify whether or not the risk reaches such a threshold that they feel like they need to step in and intervene. There was a report put out within the last 10 years that actually says they were able to survey about 26 states, and every single state had a different approach to when in the process they determined risk was or was not there, the threshold and definition of what constituted risk, and the measures that were taken after that. So I think as a result in the United States, what we're seeing, and if you work in healthcare or if you spend time with an elderly population, you see this every day, that the way that adult protective services are actually being provided is incredibly inconsistent. And it leaves family members, patients, and clinicians in a really uncomfortable gap, because at the end of the day, most of our patients and individuals and the elderly really do fall into this gray zone where they could maybe be getting a little bit of better care if they had some more support or more services, or maybe where the caregiver just doesn't have the education they need to be able to be providing the quality of care that would be most appropriate, right? And so how do we step in and how do we address those circumstances? So I want to, in addition to talking to you about law at 8 a.m., I also wanted to talk briefly about ethics and some baseline ethical principles that come into play here. So when we think about a caregiver's responsibility, we think about that they have a duty to the person that they're providing care for. I will say, unlike Taiwan, we don't have a mandatory responsibility to our family members in the United States. And it's not really something that even most ethicists would say, you as a family member have a duty or obligation to the one that you're caring for. And this is why if you spend time in a US hospital, you will notice that we have a lot of abandoned or patients without surrogates or individuals that are there living alone and without any services. It's a huge problem and a major challenge to our healthcare system. However, once somebody steps up and says, yes, I'm going to be this person's caregiver, either by default because that's the spouse and that's who they're living with, or by the daughter who moves in, or the neighbor who steps up and puts their hand up in the air and says, I will help out in this situation, they have then created a duty or a responsibility that they owe to that individual patient. And then once we have a surrogate decision maker or a caregiver, we then provide to them certain responsibilities, which is to provide care that is consistent with the individual's values. Now, in this case that we spoke about this morning, we had a remarkable woman who did more planning than about 80% of the population. I will tell you that when institutions have evaluated the percentage of people who come in with durable powers of attorneys or healthcare powers of attorneys, it's usually about 20%. You know, that 20% of the people in the United States go into hospitals, that's it. Those are the only ones that have planned far ahead. So this woman is just remarkable, really, for doing the planning that she did. But the reason why we think that kind of planning is so important is because it tells other people around them, this is what my values are. This is who I want my decision maker to be. And it's the decision maker and the caregiver's responsibility to make decisions that are consistent with that individual's values. So one of the concerns that we had in this case was that the husband seemed to really struggle with being able to provide care that was consistent with what the patient's values were and what she wanted. And you get a sense that maybe she had a hint that that was going to be a challenge based on the fact that she put a clause in her power of attorney document that said, hey, if this isn't going well, I want my sister to step up, right? Because he was responsible for the financial side of things. And so it was almost a flag that she was putting out to the world to say, I'm concerned that at some point my husband may not be able to make financial decisions that are consistent with my values for the type of care that I want. And so it's a really, really remarkable thing. When we have a situation where the caregiver can't actually speak on behalf of the patient's values, which does happen, we then kind of revert to the best interest standard. And what that just means is that for this individual, with the information that we know, what is in their best interest. Now, I think what's really important, and when we get back into this gap of this gray zone, is where we draw the line between when a caregiver or a surrogate isn't meeting their responsibilities. And I like to actually borrow from the pediatric literature here because I think that there's a really nice carryover, which is that in the pediatric literature, there's a principle called the harm principle. And the harm principle was actually a response to similar questions raised around parents making decisions for kids. Because parents have authority as parents to say, this is what kind of healthcare my kid should get, or this is the type of decision I want to make for them regarding their education. people really struggled with, but that decision is not necessarily what I would think would be in that child's best interest, right? As a healthcare provider, you're saying you're not going to consent to blood transfusions, but you're telling me that's because of your religious interests, right? And so for me, that could be a tension as a caregiver or as a healthcare provider. And so the principle that was then put forth by Douglas Diekema was that we should actually remove authority once it crosses into the realm of harm. So when a parent's decisions are don't even reach the threshold of best interest, but actually could cause harm to the child, that's when we should intervene. And I think it's actually a really nice parallel here about when we step in and when we start to really think about intervening, which is once a caregiver or a surrogate decision maker starts to make decisions that are not just not in the best interest, but actually could harm or put the patient at risk, that's when we should start to really think about what interventions can be put into place. So some of the factors that we should really consider before we get too concerned about, or we should consider when we're thinking about how we're going to step in and how to intervene is, again, because we know that adult protective services is essentially tapped out of resources and their caseloads are so high, they are a phenomenal resource. However, we also need to understand their limitations. So what as a healthcare provider can you think of to help provide more support to patients and families? So first of all, start with, does the caregiver have access to the resources that are going to be needed to provide satisfactory care and the appropriate care? This can be everything from, talking to the caregiver and asking, what do you have at home or what do you not have at home that you would need to be able to help the patient with X? In this situation, you're uncomfortable taking your wife to the bathroom. How can we help you with that situation? Or how can we give you tools that might make this easier? What skills can we teach to you? Is it that you're uncomfortable actually performing a certain task? Can we better educate you on how to do that? Is there, again, a better way to provide caregivers in the home that might be able to help? Thinking really through like what resources and not jumping immediately to the caregiver's not doing X. It's because, then all of a sudden we start to grab onto all these conclusions about this caregiver that they don't care, or they don't love the patient, or that it's actually abuse. Let's start with, what does that caregiver need, and do they have it? And then starting to wonder whether or not, is the patient making deliberate choice, or the caregiver making deliberate choices to harm the patient? And I think that that's where the red flag really starts to go up, right? So whether it's generated out of caregiver burden, so we know that when caregivers experience more burden, as that burden increases, they're more likely to be abusive. I think that that's an indicator of stress, less than an indicator of somebody who's really trying to be harmful. But really starting to think about, are they making deliberate choices, and how do we step in and intervene at that point? And then I think what this case demonstrates so beautifully is, who are the other stakeholders that we can lean on, right? Again, so even if we know that the number of caregivers that are available to any given patient is declining, inevitably there's somebody else that could step in. So I'll give you a very personal example. I actually got into Alzheimer's because I was asked by a caregiver to provide respite care as a college student. And so he looked into his community and said, hey, there's a university. I bet you I can find an 18-year-old kid that would come hang out with my wife, for a day a week, and that would provide care to me, right? So there are so many other ways and creative ways to think about, how do we support caregivers rather than immediately going to, you're a bad caregiver and you're doing this wrong. I think it's really important to step, like Bunli said this as well, is to step alongside our caregivers and help them find solutions. And again, in this case, we had such a beautiful example of a sister stepping in and really being the reason why the patient was able to get care that she needed. I have plenty more I could say, but I do want to be mindful that we wanted to reserve a lot of time for discussion. And so I think Bunli is going to join me at the mic here, and we're going to first take any questions about the case in particular, and then happy to talk about this issue more broadly. We'd love to hear some comments or conversations about the international perspectives on this.
Hi, this is Mariana. Can you hear me?
Awesome.
Yes, we can.
Hey, my friends. Hi.
GBHI
Let me see if
reunion.
my camera is working. Well, I was just talking with Camilla in the Zoom chat, and I was telling her that I am ashamed because I think that we need to work a lot on the protection and care about our elder populations. In Mexico, we have different situations because just during I don't know, maybe the last 5 years, this has been calling attention of politicians and caregivers and other people that can be decision makers. And I think that now we are thinking a little bit more about who is going to protect our elderly and who is going to take care of them when they need a lot of care, like if they have dementia or not, but not only if they are having dementia. I mean, just the fact of being elder. And I am talking about many things. How do you get into a building and there are hundreds of steps to go there? And how do you go to get your attention and healthcare attention and you have to go alone and you don't have a way to move by yourself? Or how do you go and take care of yourself if you need to get medicines and you don't have money for that? And now we have some laws that are just starting to get applied about child's taking care of their parents. I think that is very important about what Bunil was telling. But this is very, very, very early in Mexico, so I think that we have to work a lot on that. In fact, in Mexico, a lot of people that is having dementia is being cared by childs, and they are along with the childs, and you don't know who is going to take care of whom. So I think that we have to do a lot of work on that sense in Mexico.
Thank you so much. It's a really wonderful perspective.
I have a comment. I'm Sarah. I'm a nurse here at the MAC, and I am interested in this population that lives alone without, a spouse or family member, which we have a lot of in San Francisco and the U.S., and then also the rising cost of housing and, the fact that a lot of older people are becoming homeless for the first time in their 50s and, at a time when they're at higher risk for cognitive impairment, and whose responsibility is that? I think the point that Eliseo made about, it being everybody's responsibility is something we need to, take responsibility for as communities and not just families or individuals or health professionals, because it's kind of a bigger problem than any one of us can.
Okay, so I think that it's a really important point, Sarah. I think one of the ways this plays out that I've seen it the most is that what happens when patients get admitted. That's when you usually pick up on patients living alone. And what I have found really interesting is that I worked at a prior institution that had a patient without surrogate policy, meaning that we had a mechanism to put into place when we had somebody that was admitted without a caregiver or without a surrogate decision maker to make decisions on behalf of that patient. And it wasn't just the clinician saying, oh, I think this is what best. We actually had a community level approach on how that was to be done. What I learned and have since learned from that is that that's not universal at all institutions. In fact, some institutions are actually very stumped as to what happens when somebody comes in and they're alone without somebody else to make it. So I think even from a policy perspective, finding mechanisms to improve hospital level policies, because what that patient without surrogate policy allowed for was allowing for a better safe discharge, which is really, really important, right? Particularly in a city like San Francisco, is that if somebody's admitted, they're alone and they can no longer provide care, that we don't just send them back out without the support that they need. And so I think that that's one example in my head that I think about. This is a place that we could be doing better policy-wide and more universally, is making sure that hospitals have these policies, because they're hugely helpful to making sure people get the kind of care they need. You were gonna.
I was actually just wondering, when we say everybody is taking responsibility, would it be that then everybody is hesitant to take responsibility? If you share the responsibility to everyone, sometimes people felt less, the bystander kind of, if you have 10 cars over there versus that you have one car and then you see a car accident, who's going to act? When it's shared, people are less motivated to act, and that's actually one of I think one of my concern is But I also can see that, people can act on very different level. And one thing I think Mariana brought up was, try to get in place policy that decrease the level of dependency of the elder population. So the less dependent they are, the less likely they are subjected to abuse, I gather. But yeah, I agree with healthcare providers being like one of the major role. I'm just not sure, like, if we put everybody and no one's leading this movement, is it then nothing would change?
Hi, thank you so much for this. I'm Barbara Kamholtz. I'm a geriatric psychiatrist, and I work with the UCSF Global Mental Health Fellowship. And one of our sites is in far west Nepal, which is an extremely rural area. And I've done a lot of work with delirium, and the first person they asked me to see was an older woman with delirium for a urinary tract infection. And of course, I thought, well, we have to be sure that that's the right antibiotic. We've got to keep her in at least 2 or 3 days. The daughter-in-law, who was obliged to take care of the mother-in-law, was looking at me beseechingly for days. And I don't speak Nepali. I have a few words, but I was, asking. The issue is, as in many lower and middle income countries, women have to do everything. This woman was responsible for, schlepping fodder up the mountain for the animals, taking care of the animals, taking care of the children, providing all the food, making sure that the farmstead was intact. So every day that she was at the hospital, and they had to stay at the hospital to have a patient there, her farm was falling apart, which could have massive, social and economic repercussions. And in a place like Nepal, it is so mountainous that, to get someone to the hospital requires the strongest and probably most functional person to carry them down the mountain and sit on the bus for 10 hours and get to the hospital and stay with them. And if that most functional person happens to be the primary wage earner, if they're lucky enough to have a job, then the financial implications are profound. So the thing that was really troubling me was the nonprofit that works there is basically founded by someone from here, UCSF, Biva Bashari, who's an amazing guy. And the care is great, and the care is all free, and they get support from the Nepali government, which, by the way, has got some manifestos out about how much respect geriatric people should have. But their feeling is there are very few resources. They have to all be spent on immediate, risks right in front of them. Maternal, issues, child accidents, that sort of thing. And there simply isn't. There are no resources for geriatric people. And my thought is, well, there's a social justice aspect, but also, the older people are simply not getting enough care, and then they may end up, in worse shape. But I suppose you could say if you keep the younger people healthy enough, it'll be more of an issue going on. So I have no answer to this. I just find it extremely perplexing and really compelling. So thanks.
I really love that point, in part because I think it's something that we're seeing globally. Even in the U.S. right now, I think that, you think about what Medicaid is supposed to cover and how much healthcare, but ultimately that's paid through state budgets. So, one of the pushbacks I always say about relying on Medicaid to provide long-term care is, if we rely on Medicaid to provide long-term care, that money's got to come from somewhere, and it's likely to come from our schools and our prisons, which are, already strapped. So it's an ongoing balance, I think, from a policy perspective, to think about how do we make sure that we're providing the care that's needed, and how can we, maybe do it a little bit more cost effectively.
If I may, why does it have to, for the money to transition from other social services rather than defense, for example?
Yeah. So Michael did a nice job of just answering this, like he can be the lawyer in the room maybe. But so basically the way that Medicaid is paid for is through state budgets. And so as a result, it's a state resource. So that has to come out of the state budget and not a federal budget. So that's really why there's so much pressure on our Medicaid system right now. We have a comment from our fantastic social worker here. So I have
a social worker anyway. This is Mark Thoma, social worker here at the MAC. I think that was Eliseo. And I just want to echo his comment. To me, it's also, in addition to what other people said, an economic justice issue, at least in the United States. We have such a gap in, if you just look at the tax package that was passed and who benefits from that, which is a very small minority of our population, and the vast majority of the population does not benefit from that. So when we ask, well, where would the money come from? I think as a nation, it has to come from us, and then we have to decide that we're going to take care of our elderly population better. And so then we come up with economically just way to do that. And instead of just taking it, from Peter, what is that, Rob, Peter to give to Paul, it just has to be much more. I think it needs a big cleaning out, I guess.
Can I add a comment on that? So actually, when Jolene was talking about cost effective, it kind of reminded me of this report that I saw where, so they actually look at the informal cost of different countries based on their, country income. And so, and then the x-axis is actually the age, and then the y-axis is the amount of money that you are spending. So for all different income, like low income, or upper middle income, everyone is actually gradually going downwards. Whereas the high income country is actually going remarkably high. So it means that for high income country, elder population just spend so much more as they age. And I'm guessing a lot of that is for healthcare cost. And then I think that kind of reminds me of when you're saying about cost effectiveness. If like low and middle income country can do it with relatively lower costs, is it still also possible to make that happen in a more high-income countries? Or is it just basically because of the healthcare standards?
Sorry, one more comment. Also, at least in this country, the majority, I don't know, I don't have the statistics, so this is just anecdotally, but it seems that the care provided to the elderly is mostly by women, not paid well, often doesn't come with benefits. At least in the Bay Area, a lot of immigrant populations also provide care, again, often without benefits and job security. So just in terms of changing the whole status of caregiving, I think that there's a lot of room for improvement there in the country too.
Mark, I'll just let you know that there's a researcher in Harvard whose name is currently escaping me, but she's actually working on this, and I got to see her present some preliminary work about 2 years ago, and everything you just reported is like maps on exactly to what she's finding, and she's actually done a historical look as to why that is the case. And she, in the U.S., she talks it actually back to slavery, and she says because slavery was such a pivotal or such a key component of our history, the minority women population kind of got perceived or categorized into that role, and we haven't been able to like shift out of that. And that's really how formal caregivers, again, this is her data, not my perception, that is how caregivers are perceived. And as a result, that has become I think most people who work in the industry know that this is a very underpaid position. And there's a lack of education that goes along with that. And so it's creating a really, there's a lot of things that are going on right now in long-term care in the US, but the workforce is a huge challenge that we need to find better solutions to.
Jolene.
Yes.
Sorry, this is Jenny speaking. Can I ask a question?
Go for it.
Yes.
Okay. I was just wondering, since I don't know how the laws are here, what's the role of while you're still working before you get to pension age? Is it here mandatory to save for pension, or that's something that you do if you want? And what role does that play for paying for your future healthcare, if any?
Okay. So it is not required at all. In fact, it's such a great question, Jenny. I will tell you that the research that I've been doing has really found a lot of reports indicating that people are not just unprepared for long-term care services that they might need as they age, but they're globally unprepared for retirement. And it's honestly just getting worse with our generation. And particularly in Social Security is required, but Social Security doesn't pay for much. Yeah. Correct. Yeah. So not all work contributes to Social Security. So, we're a country that is getting to retirement without the funds to pay for our retirement and or to pay for the services we might need as we age. I think Cindy has some wise comments she looked like she was about to make now. Okay. I just look at Cindy, she's got so much wisdom. So, so I think it's it compounds the issue.
I did have a question or comment. So this is Cindy Barton. I'm a nurse here, and I spend a lot of time counseling and talking with caregivers. So I was really struck about the caregiver in this case, and the fact that he
was identified early on as not wanting to be a caregiver or not being able to be a caregiver. And then I was struck again when we were looking at the harm, and there was this use of the word deliberate, which has such a sort of strong volitional component versus not being able to do it. And I think that there are a lot of caregivers I've worked with over the years who are forced to do something that they realize they cannot. And are not able to do. And we don't have, in this case, she identified her sister, and we were lucky to have her sister step up. But there's the public guardianship system in this country, or the support for people who can't do it, isn't there.
Yeah, so I just wanted to point out, that's why I was trying to make that distinction, is, you know, really talking to caregivers about the resources that they need and maybe don't have, and distinguishing that from the caregivers that are deliberately causing harm. I think the latter is the one where you really want to make sure that you're stepping in and intervening, and the former, I think, is a place for an opportunity to step in and to help.
Yeah, this is Salvo Spina. I want to echo what Cindy was saying. So in the demographics that you showed before, I mean, so most of patients who are having these difficulties, they have as immediately identifiable caregiver, their spouse, which has very often like at the same age and probably also in the process of developing himself a cognitive impairment that can affect either his ability to understand the need or actually comply with the need. So I was wondering whether as clinician we can actually also start building a tool that help us screening caregivers when it's quite obvious that the person that comes to clinic with the patient is going to be the designated caregiver. But we very often have the feeling that we are talking to two patients instead of one. But for the structure, for the nature of our work, of course, we only take care of one person at a time. So I wonder whether we can think about methods in clinic that can actually help us identifying this problem.
What you said about, you know, going from 7 caregivers per patient to 3 caregivers per patient. And one thing I think in terms of not taking advantage of resources, like the sister was an amazing caregiver. And I imagine, you know, for these people, I mean, I've found for myself, if I have a sense that someone doesn't want to do it, whether or not what their capability is, they're never going to do, education isn't going to help, resources aren't going to help. Like, you just have to move on. But you know, the problem is we don't have another option often. So it's great that we have the sister, but you know, can we clone these people, or you know, when they're done taking it, like how do we get the most out of these 3 people who are good options in the world? You know, like Mark was saying, the role is unpaid, it's, you know, unrespected a lot of times, but you know, does it have to be that way? I mean, I think they're doing really important work, and if there was a way to like, you know, I don't know, have some kind of role that was respected and paid for.
I actually want to respond to Salvo's question about stepping in when we think that a caregiver may actually lack capacity themselves to serve in this role. One of the reasons why that is so challenging is because of the laws around patient-physician relationships, right? And so there are certain sort of triggers that establish a physician-patient relationship and create that fiduciary duty that you have to the patient. Because the caregiver that's in the room is not your patient, it actually, it kind of steps outside your scope to then evaluate them. And this is why it becomes such a huge problem. So unless there's a situation where they are both your patient and you establish that fiduciary duty with both of them, it's actually crossing a boundary to then evaluate them. And this is one of the big issues that has come up for clinicians and honestly ethicists around the country is, what do we do when we know that the caregiver seems to be having similar challenges themselves, and we can't cross that bound to say, all right, we're going to put you through a capacity eval to demonstrate that you can't be making decisions so that we can remove you as the decision maker or the caregiver. It actually takes quite a lot to remove a spouse as a caregiver, and it does almost require that they go through the whole APS, Adult Protective Services, into probate, and then the probate court ultimately has to make the decision to remove them. And so that is why that is such a complicated issue. It probably is another thing that we could add to the laundry list of policies that we should be reevaluating in the United States. potentially globally, because I don't know how this is done elsewhere, but it's a question that comes up frequently, and I think it's also something that's very frustrating to clinicians as to what do I do when I can tell the husband isn't in this role. But I do think also as a clinician, we should be supporting caregivers when they say, I don't want to do this, and not shaming them in some ways or treating them like, well, then you're clearly not a good spouse, because that may actually be the best thing that spouse can tell you, is to be honest and candid and say, I don't want to do this. I don't feel like I'm equipped. If you explore that with them a little bit, then maybe we can start to find better solutions rather than trying to force a square peg into a round hole.
There's also a fair amount of literature, good evidence that at least 50% of caregivers suffer significant depression, and probably 50 to 60% have thoughts of suicide, and there's a major risk there. It's really shocking. So, and that puts their health at risk, at which point, then the system cascades and you need an additional caregiver. And also, as a psychiatrist I'm old enough to have had a little bit of psychoanalytic training, and it's extremely helpful with these family systems, because you see this is the time when all the old family conflicts come out. There's guilt, there's anger, there's punishment, there are all kinds of things that you have to help these people work with if they are to maintain sanity and be able to be effective. So it's actually a very complex system.
Yeah, I think it's actually important to kind of balance the quality of the patients as well as the quality of the caregiver. I think it should also, if you make it easy for the caregiver, they are well supported, and it's likely that, they are less stressed and the risk of them being abusive is lower. But actually we have like less than 10 minutes, and I wonder whether there's any chance that, fellows from other countries outside of US can share their experience with us, because I really think that, other country with, different kinds of household may have, different kind of methods or ways that we can actually share and learn from. Anyone volunteer?
Sure, I can share.
Awesome, thank you.
I'm Elena. I'm a neuropsychology fellow at the MAC, and I'm originally from Kyrgyzstan. We struggle with many struggles that most low education countries do. But at the same time, I was kind of wondering about, we are talking about these interventions for caregivers. I do think education is extremely important. But at the same time, like Jelaine mentioned, if a caregiver comes up and says, I cannot do this anymore, we should support them. And I kind of cannot see the likelihood of that happening in most Asian countries and communities where family, obligation, duty, all that is a part of the culture. So I'm wondering if interventions for these systems where kind of the family, you're working with a group, with a group of people, should be different, not just sort of on a level of, of spouse, of one caregiver, one primary caregiver, but rather on a family level. Education, I think, needs to be encouraged, but also has to be a part of what the cultural values are, because I find it very difficult to say to a family who has grown up thinking that it's their duty to take care of their elders to say, it's fine if you cannot do it. I don't see clinically how that would work on a larger level.
Yeah, I actually think that's a very good comment. I think in Asia, like, the fact that you'll be jailed because you don't provide the necessity is actually a reflection of, how the culture is quite different. And I actually like the idea of like approaching it in a family unit instead of an particular individual, so that the burden can be shared and, more supported. Thank you for sharing your experience. Anyone else? Maybe someone from the Latin America? Yay! Talita, go!
I think there are a lot of similarities to what you just mentioned. And as in Taiwan, I'm Talita. I'm one of the GBHI fellows.
The awesome Talita?
As in Taiwan, it is legally the responsibility of families to provide care for older adults. But however, if you don't have a family member to provide care, it's the responsibility of the state to provide you with housing. And that's generally, we don't have a lot of long-term care placements or infrastructure for either hospice or other kinds of institutions, but the ones that we do have are usually aimed to the population that is homeless and has no family member to provide that care. And I'm kind of find it interesting that is the responsibility of no one here in the United States, and wonder what can be done policy-wise for the homeless population that we see clearly in the city. But other than that, I think it's very similar culturally to what was discussed.
So the homeless is more better well taken care of comparing with someone that has a home? No?
I don't know, I can't comment on the quality of care. Not at all commenting on quality, on how I was provided. I'm just commenting policy-wise for someone that is older. It is the responsibility of the state.
Say if I'm a very evil person.
Federal level, yeah.
So can I like make my family homeless and then so that they get a place to stay?
You are legally responsible for a family, but if you don't have a family, it's the responsibility of the state.
Okay. Anyone else?
Good morning, I'm Maritza, I'm from Peru. I was reading that in Peru, our elder population are suffering about 50% of people, 50% of elder population is suffering abuse. I don't believe this percentage is true because I think this is more because this paper was, this research was developed in population in the capital in Lima, in a population with low income or with money, but in rural population, we don't have any statistic. Probably this percentage is more. We don't have any specific law for protect our elder population. And I think that in our rural population, we have a good experience still because our elder population is in our rural population is like a leader sometimes. They have a lot of respect, but this is only in rural population. In very rural population, like jungle and mountain. In some small towns, our elder population is considering still as a leader in this population. But in the capital, in other big cities, they have a lot of abuse, and we don't have any law for protect directly this population.
I think Marissa mentioned a very important point. I think even though we generalize them into regions, actually I think each country is quite unique, and even like different regions within the country is also quite unique. You can see that someone that's, if the study was done in a rural area versus one in a, you know, in the city, it's like things are quite, the demographic actually changes quite drastically. So yeah, I think that's actually what is also kind of important to consider. But that's actually wonder, like, you know, if someone, an elderly at the rural environment in Peru, if they suffer from cognitive problems, would they be also, you know, being respected the same way?
Usually, my pilot project is about cognitive state in rural population. We are exploring still, but yeah, probably they have cognitive issues or functional issues too. But in the same way, in this very, very rural population, our adults have a lot of respect still. Whatever will be they, yeah.
Interesting. You want to have the last comment?
I feel like I've spoken a lot.
Yeah, well, yes.
Time for one more?
Yeah, sure.
Okay.
Well, my last concern, I guess, is that even though we develop these laws for elder abuse in developing countries, one of my main concerns when it comes to cognitive impairment is that they are not especially being paid attention to, because it is not the same even though the state provides you with housing or with long-term care or whatever. People with cognitive impairment have very, very special requirements. And if the people that are in these spaces not adequately educated to provide them, I think it's going to be even more challenging, and that mistreatment in these places might actually go up instead of down, which is what we are looking for. So I think it is very important for us to also advocate within this. I mean, if people cannot stay with their families for whatever reason and they have to go to a facility that is provided by the government, to actually be aware that these special needs of the population will be covered. Yeah, sorry, I'm Stephanie. I'm a GVHI fellow from Mexico as well.
Yeah, well, I agree very much. So thank you everyone for attending the session today and sharing your thoughts on things. I think has been very inspiring for all of us. But I want to especially thank the family as well as the patients, I think, which has this inspiring story that allows us to, discuss this topic in depth. We didn't provide all the details, but if you have any chance of, going through her notes, you'll find that she's truly an inspiration. And also the family caregiver that step up when needed to be. And also, I think we would like to especially thank Sarah and Salvo for, helping us preparing for the session today, and all of you for sharing your thoughts and time with us, as well as Camelia and Michael. Gosh, me. So yes, that makes this possible. They organize everything, help out with the technology, which was really important. And as well as Jelaine, yeah, and everyone. Yeah, thank you.
And of course, we want to comments, and real quick, we're going to be sending out a survey afterwards. It would be wonderful if you could complete it, and we'll share the PowerPoint slides with you. So thank you everyone from near and far, and again, thank you to Bunlead and Jelaine. Thank you. Yay.